Welcome to the JACC Journal Club. Thank you, everybody, for joining. And we'll go ahead and start off with just an introduction of what we're doing here. Welcome to JACC Journal Club. This is a new initiative from JACC. I'm Vivek Kulkarni. I'm the JACC Education Editor. Journal Club is a new program in which we're going to be highlighting articles that are published in JACC that we think are particularly relevant for fellows, trainees to learn about the advances in the field of cardiology. There's a number of resources we're creating for that. There's a website that we've made. The QR code's available here if you want to go ahead and check it out. We've got slides. There's author interviews available. And this is our first live webinar discussion where we'll be having sort of a live Journal Club discussion of an article aimed at trainees, but featuring the authors of the article. So we're very happy to be doing the first one. This is the article we'll be talking about today. Tirzepatide reduces LV mass and pericardiac adipose tissue in obesity-related heart failure, the SUMMIT CMR Substudy. This article was published in JACC just a few days ago and announced at AHA. Natalie Stokes, Harish Jarrett, and I were the ones who put together this presentation. So thank you guys for your hard work and welcome everybody. We don't have any disclosures. And as mentioned, this article was just published in JACC. If you would like to access the full PDF and the website, you can use the QR code on the screen right now. Full disclosure, I'm not sure why the QR code I created ended up with a dinosaur in it, but that's okay. Hopefully that's enjoyable to everybody. And I'd like to welcome our panelists and introduce them and give them a minute to say hello. First is Dr. Chris Kramer. He is the first author on this paper. He's the George A. Beller and Lantheus Medical Imaging Distinguished Professor of Cardiovascular Medicine and Chief of the Cardiovascular Division at UVA. Dr. Kramer, thank you for joining us.
Thanks for having me. It's excited to be here.
And our second panelist is Dr. Milton Packer, who has a large number of titles, and it would take a long time for me to announce them all. But suffice to say, Dr. Packer has been a force in the field of cardiology and heart failure for 40 years or so, and is also on the JACC board in the interest of full disclosure. But thank you very much, Milton, for joining us.
I'm delighted to be with you on the first inaugural session, so it's great.
And I'm glad that your cat has also decided to join us today.
Yeah, she's excited.
So this is just a brief overview of what we're going to talk about today. We're going to start with a brief overview of the main SUMMIT trial, which was published in the New England Journal of Medicine. This is not a journal club specifically for the main paper, so we won't be diving into great depth in the main paper. We will be diving into great depth into the SUMMIT CMR Substudy. We'll go into that article in a lot more detail. All along, and then at the end, after that, we'll have a chat-based Q&A. So if you in the audience have questions for the authors, what I would encourage you to do is please type them in the chat as we're going along. We will likely not address the questions until the end when we have our Q&A session, but if you type them in the chat as we go along, then we'll have an ongoing record and we can take a look as we go. All right, well, thank you, everybody. I'm going to turn it over to Natalie Stokes now.
Thanks so much, Vivek. So I am going to provide a very cursory overview of the SUMMIT trial. I encourage you to do a deep dive, but that's not the purpose of our journal club today. And this should provide a launching pad for the MRI substudy we're going to discuss. So as background, obesity and HFpEF are concurrent health epidemics that are extensively intermingled. And this slide illustrates the multiple pathways through which obesity can impact myocardial function and manifest in heart failure, both with anti-natriuretic effects as well as pro-inflammatory effects, which can impact filling volumes and compliance. Dr. Kramer, I don't want to take up too much of our time here, but is there anything specific you'd like to comment on, especially as it will pertain to our discussion tonight?
Yeah, first of all, I have to give credit to Dr. Packer for this slide because he actually created the slide. But yeah, I think the volume expansion along with the increased LV mass leads to and the non-compliance leads to inability to tolerate the increased volume load. So then you end up with a clinical scenario of HFpEF.
Excellent. So the SUMMIT trial design was a prospective randomized double-blind placebo-controlled trial looking at Tirzepatide, a combined GLP-1 receptor agonist and GIP receptor agonist. The combined endpoint of death and worsening heart failure events in obesity-related HFpEF. Patients with NYHA class 2 through 4 symptoms, EF greater than 50%, and a BMI greater than 30, with additional enrichment criteria to ensure high clinical risk were included. And this just shows the time frame here. So they were randomized they were screened and randomized, and there was a double-blind approach, and that was maintained until the last patient completed 52 weeks, which is an important time point for our study today. And then, as I'm sure you all are aware, the primary endpoint, this was a very positive study, both primary and all secondary endpoints. And you can see here the main figure, so that primary endpoint of cardiovascular death or worsening heart failure event. It was markedly positive quite early on in the Tirzepatide group. It is also worth noting some of the secondary endpoints specifically is that the Tirzepatide group did achieve significant weight loss, and there was a drop in CRP. And now, before we move on, I know that was quite quick, but Dr. Packer, what would you like to mention from the primary SUMMIT study that might be helpful for us as we start to talk about the CMR study?
Well, it's really interesting because, as you said, HFpEF and obesity are the overlap between the two is quite substantial. It is probably true that 70–80% of HFpEF is related to obesity. And therefore, if you have a drug that reduces obesity, you would expect to have a drug that would have an effect on HFpEF. What's remarkable here is that we have other drugs that have been shown to be effective to varying degrees in HFpEF, but the effect sizes have been reasonably modest, 13%, 15%, 18% reduction in risk. This is a 38% reduction in risk. By the way, this is very consistent with parallel data with semaglutide in obesity-related HFpEF. So there's not only internal validation, but external validation.
Fantastic. So now with the SUMMIT CMR study that we are going to be focused on today, this was to address the among patients in the SUMMIT trial assessed with cardiac MRI. Sorry, can you go back?
Sorry about that. I think we popped over this slide by accident.
Oh, yeah, that's okay. So background for our specific study is obesity-related HFpEF, as we have mentioned, is a specific phenotype. It's accompanied by epicardial adipose tissue, and this is even potentially a contributor to obesity-related HFpEF. Mechanisms in which it is supposed to act in a paracrine manner: pro-inflammatory cytokines. It also has extrinsic compression of the heart, which can impair filling, and it reduces secretion of natriuretic peptides, which contributes to that imbalance with increased filling with less compliance. And importantly, concentric hypertrophy that does result in increased LV mass has also been shown to be more severe in obesity-related HFpEF. So from this, we have our research question. So among patients in the SUMMIT trial assessed with cardiac MRI, does Tirzepatide reduce LV mass and epicardial adipose tissue? So Dr. Kramer, if you can tell us a little bit about how you came up with this research question and how did you come up with the idea for this study?
Yeah, we're trying to understand the mechanisms of potential benefit of Tirzepatide ahead of time, and working with the funders, decided to do a CMR sub-study, really aimed and powered to show that tirzepatide reduces LV mass. Just as a way of background, the STEP-F echo sub-study, which had nearly 500 patients, did not show a difference in LV mass with semaglutide. Now, that may be because semaglutide doesn't reduce LV mass. It also may be that they chose the wrong imaging study to measure changes in LV mass. Echo is far less accurate, less reproducible than CMR. The prior studies of antihypertensive drugs with CMR, you can see differences in LV mass with 50 patients in a group, and that's how we chose to power it. And that was the primary endpoint. We certainly were interested in all the volumes, epicardial adipose, et cetera, but the primary endpoint was LV mass, and that's what the study was powered to show.
Great, thank you. And Harish is going to get a little bit into the details about the MRI aspect.
All right, so study design is pretty elegant. Patients obviously with sub-study were encouraged to participate in the CMR arm. What I like about the protocol is that it is a standard clinically obtainable protocol that was done on regular clinical scanners at 1.5 or 3 Tesla. And then similarly, image analysis was done actually on commercially available CMR software. Images were analyzed by an expert reader, and essentially standard acquisition of volumes and mass calculations, et cetera, were performed. Non-clinical features that were done include strain, radial, circumferential, and longitudinal strain, but again, easily accessible to CMR programs. And then left atrial parameters, volume, and left atrial strain were assessed as well. So before I get there, Dr. Kramer, I have a question for you, I guess. This was done essentially one expert individual analyzed the software and then analyzed the images and used some creative finagling, shall we say, to figure out the epicardial mass and or fat mass and pericardial mass. How reasonable do you think this is for a clinical high volume or moderate volume center to reproduce, and is it even relevant to do so in studies that are concerning for HFpEF?
Yeah, I'm not sure that it needs to be done clinically per se. I think it's in the realm of research at this point until we find a clinical reason to measure it. It does take some training to measuring LV volumes and mass is very straightforward. A fellow can learn in a week how to do that. The mass, the epicardial and pericardial fat is a little trickier. You really have to take some time to identify the pericardium, which isn't always obvious in every patient. And so it took, this is an image analyst who has 25 years working in my laboratory. So he's a very experienced analyst, and it took him time and some learning curve to really learn how to do it correctly and well. And we measured it on the short axis images, and we did cover the entire heart from the apex all the way to the posterior wall of the left atrium with contiguous short axis images, so no skips, and measured every slice, so every bit of LV mass and every bit of pericardiac adipose.
Well, it's really commendable. Must have been time consuming for JD, I'm sure. Yeah, just there's a clinical or distinction between essentially pericardial and epicardial adipose that was termed pericardiac adipose tissue for analysis purposes.
Yeah, just to point out, there were at baseline, there was 4 times as much pericardial fat in this patient group as epicardial fat, right? We always talk about epicardial fat, EAT, but there was 4 times as much pericardial fat in this patient in obese HFpEF.
And then the primary endpoints for this sub-study, again, as we mentioned earlier, LV mass was the point of relevance, and then secondary endpoints were epicardial and pericardial adipose tissue volume. And then if there was any change in functional parameters that we look at, LV and left ventricle and left atrial volume, and then any change in strain parameters within the left ventricle and left atrium specifically.
Dr. Kramer, I actually had a question for you here, which is, given the supposed role of epicardial and pericardial fat in the pathogenesis of heart failure, especially HFpEF with obesity, why not make that the primary endpoint? You mentioned that the study was powered for a primary endpoint of LV mass. Just from a study design standpoint, would you mind explaining why not use the actual adipose tissue as the primary endpoint?
Because there weren't enough data in the literature to power a study in terms of knowing how much there was, how much it would change. So it would be a blind study design essentially to try to power it off of adipose tissue. There were no real MR studies of changes over time in adipose with any therapy. There's more data in the literature on CT. The methods, every paper you look at uses a little bit slightly different method to measure adipose, epicardial and pericardial adipose tissue. So there was really no way to power a study adequately based on adipose tissue. And in mass, there's excellent data from 20 years ago on mass changes with antihypertensive therapy. So it was much more straightforward to power it based on LV mass. Certainly, we were interested in the adipose tissue for sure from the start. We had some thoughts about doing a slice of abdominal imaging to get visceral fat in the abdomen, but we really wanted to simplify the protocol as much as we could. The sites were mostly second and third world sites, so these are not they weren't chosen for their ability to do CMR. So we really tried to simplify it as much as we could to try to get as much data out as we could.
And then the kind of workflow here for the patients, about 175 patients underwent baseline imaging, as you can see. Interestingly, about a third of patients had kind of incomplete data and had to be excluded, and then 117 ultimately got re-imaged at 52 weeks. That amounts to reasonable attrition at 175 patients down. Dr. Kramer, I think this was pretty par for the course with clinical kind of CMR, given I think about 20% of the patient population had atrial fibrillation as well. Do you think that the attrition was reasonable?
I think, again, it relates to what I said a moment ago, is that the sites were not chosen for their expertise in CMR, and they weren't that necessarily that experienced. And so there were issues with, incomplete coverage, and poor, these images. Most of the loss was incomplete coverage. There was some poor quality images. Obese patients are harder to image. The gating and breath holding can be more of a problem for them. So there were a few dropouts because of poor image quality at baseline or a week 52. But it was just an issue mostly with inexperienced sites and incomplete data capture. I think, if you did this same study and experienced, North American sites, we would have had 150 patients in the final end rather than 117, and then obviously there was some loss because of events and just poor timing of the scanning, etc.
Right, and with that, the baseline demographics of the enrolled study population, so the 106 that completed the sub-study, and notably no differences between this sub-study population and the SUMMIT population at large, and no significant differences between the two groups. It's about 50% female, excuse me, average age of 65, and then the race distribution does reflect that fact that the majority of patients were recruited from Argentina and Brazil, about 85% Hispanic or Latino and 78% white. BMI, NYHA class, you can see here the majority were class 2, about 20% class 3, about half had type 2 diabetes, and the NT-proBNP numbers are here, but the median between the three groups was not different. I mean, between the two groups, rather, was not different. Other characteristics just worth noting, we already mentioned AFib was present about 20%, and coronary disease present in about 20% as well. Now, importantly, onto the results. So with regards to the primary endpoint of LV mass, you can see here there was a significant reduction in the tirzepatide group of 11 grams. And I think, interestingly, while it's not statistically significant, the LV end diastolic volume did also decrease in the tirzepatide group, which I actually wanted to pick your brain on a little bit, Dr. Packer, and see if you have any thoughts on that.
Well, the slide that you showed earlier, that the obesity has adipocytes that secrete anti-natriuretic effects. So there's volume expansion, and a lot of cardiologists think that left ventricular volumes in patients with HFpEF are small. They're not. They are typically mildly enlarged, largely because of plasma volume expansion in a non-distensible left ventricle, but they're not small. They're small in hypertrophic cardiomyopathy, but not HFpEF. So big difference. So if you reduced plasma volume expansion, and Barry Borlaug, who was part of our team and published a paper in Nature Medicine on estimated plasma volume, which went down with tirzepatide very strikingly. If you do that, you would expect LV volumes to go down as well. And here, if we had more patients, we probably would have seen it.
Interesting. Thank you. And so we'll talk a little bit more about the primary endpoint and its meaning and next steps when we conclude. But just to get to a few more of the results, the tirzepatide group, and we can go on to the next slide, actually. The tirzepatide group did show a change in LV mass, which correlated with the change in body weight. And although not statistically significant, it was trending to correlate with waist adiposity as well, which is something that I think we had mentioned before, potentially considering in terms of parameters. Our next slide shows the impact on the left atrial structure and function. And interestingly, the study did not show any significant changes in left atrial volumes or strain between the treatment groups. And I actually just wanted to pick your brain on this, Dr. Kramer. So given the importance of left atrium in HFpEF pathophysiology, as well as what had been seen previously in the semaglutide echocardiogram studies, why do you think that we didn't see an impact here?
Well, actually, if you look at the under the hood at the STEPHF trial, semaglutide attenuated the increase in left atrial volume in the placebo group. So in that study, the placebo group, there was over a course of a year, there's a 12 milliliter increase in the placebo group, and only a 6 milliliter increase in the semaglutide group. So we actually saw if you look, there's a 7 ml decrease in the tirzepatide group, but interestingly, there was a 5 ml decrease in the placebo group. So no statistical difference. Now, some of this may be methodology in that we used a biplane method just because of time. We have all the slices, and we're going to go back and do this. do it in a 3D fashion, because we have every slice of the left atrium, and it probably will be more accurate, and maybe we will see a difference when we measure it in a 3D fashion rather than a biplane fashion. That being said, there was a decrease in the tirzepatide group, probably not statistically significant, but there was a parallel decrease in the placebo group. So yeah, I mean, the hope is that you, as Milton said, volumes decrease because of the pro-natriuretic effect of this drug. And I think we see this. It just, again, because of the N, because of the methodology, we're not seeing statistical significance. Milton, anything you want to add there?
Nope.
And then also our secondary endpoint, we had spoken about the pericardiac adipose tissue, which was inclusive of both the epicardial and pericardial adipose tissue. And you can see there was a significant difference in reduction, but that was largely driven by the pericardial adipose tissue. And I think, Dr. Kramer, you had mentioned before that the baseline pericardial adipose tissue was quite prominent. And why do you think that the driver of this was the pericardial versus epicardial tissue? And do you think, how does that make you think clinically about your research question initially going into it?
Yeah, so, I think going into it, we didn't know how much more pericardial fat there would be compared to epicardial. There is, if you look at the, I don't know if you're going to show the images, the representative images.
Yeah.
There's just not that much epicardial fat in these patients. So yeah, I think these images are really instructive. So if you look, the pericardium is pointed to by the orange arrow. And so let's look at it. First of all, the top images are the baseline images. The bottom images are 52 weeks. The tirzepatide patient, just lost the screen. There we go.
Okay, I think we're back.
Okay. So the orange arrow points to the pericardium, with thin gray line. And the star, I'm sorry, I didn't finish explaining the images. The top are baseline, bottom are 52 weeks, left is tirzepatide, a treated group, right are placebo. So top left is a baseline tirzepatide patient. Gray line is with the orange arrow is the pericardium, and the star is in the epicardial fat. See how little there is compared to the blue or black arrow outside the pericardium. The pericardial fat, tremendous amount of fat, much more than the epicardial fat. And then if you look down at 52 weeks in the tirzepatide, it looks, there's some, yeah, if you could,
Sorry about that.
don't hit end session, I don't think. But that's, can we move that box? Is there a way to move that box? Yeah, don't. Yeah,
See if we can, if we do that, there we go.
All right, so look at the pericardial fat. It's melted away, the black arrow. The epicardial fat didn't change much. The pericardial fat melted away compared to the baseline. Look at the subcutaneous fat outside the chest wall. Look how much less there is than at baseline in the tirzepatide. Fat melts away. The placebo group, you can see there's really no change. In fact, subcutaneous fat, I would argue, increases. The pericardial fat may increase in this patient individual as well. There is a susceptibility artifact in the image, but you can see how much pericardial fat there is, again, compared to the lesser amount of epicardial fat. So there's just more pericardial fat to lose in these patients. And I think that's why you see the change there. There was a change in both groups in the epicardial fat that paralleled the change in pericardial fat, but there was just as much drop in the placebo group for whatever reason. And the big change is in the pericardial fat, which is visceral fat.
And do you think mechanistically there's any contribution of visceral compressive forces that might be?
So I'm going to be honest with you here. I the concept of pericardial restraint by fat, I have a problem with. I mean, I image hearts with MR all the time, and I see constrictive pericarditis, and then there's constriction. You can see that. I just don't see compression of the pericardium or the RV or the heart by fat. Fat, as you know, think about fat, it's loose tissue. So I think the major effect in my mind, well, I think there on the fat is the change in the adipocytokines and the reduction in this the neurohormonal effect of adipocytokines. I'm not a huge believer in this restraint concept, to be honest. I think the change in mass of just to back up to the mass concept, at baseline, these hearts were 20% bigger than normal. If you look at the literature, obviously we didn't have controls in this study, but in men, the mass was 140, normal being about 120, and in women it was about 100 grams, normal being about 80. So 20 grams higher in both genders than normal, and the Tirzepatide reduced that and it attenuated that increase by half. So there was a 10 or 11 gram drop in the Tirzepatide. So not all the way back to normal, but well towards normal. And, you know, again, it was a 52-week study. We know there's continued weight loss beyond 52 weeks with Tirzepatide. It doesn't plateau until about 72 weeks. So if we follow the patients longer, there may have been, you know, continued decline in hypertrophy. And for that matter, paracardiac adipose.
Oh, that was great. Thank you, Dr. Kramer. Just going to mention some limitations, but I think we've actually gone through these as we have spoken. The image inadequacies we talked about, and I think it's pretty well explained that these were done in developing nations, and probably tissue characterization probably not available with respect to T1 mapping and additional metrics like ECV calculation and so on. Gadolinium enhancement was not done. I'm not sure it was necessarily required or needed. And then right ventricular structure and function not assessed. I'm assuming it's possible to do that going back.
We're going to go ahead and we're going to moving forward. That's our next step. We're going to measure RV volumes, the 3D LA and RA volumes as well. So we just, you know, to get the paper out in time for AHA, there wasn't time to do all that additional analysis. Just a word about T1 mapping. You know, we really would have loved to do that, right? So mass fell is that, you know, myocyte mass or extracellular mass. You know, my hypothesis is both, right? If you do an AVR in someone with AS, both myocytes and extracellular volume drop in parallel. So I expected both would decline in parallel, but we don't know that without doing T1 mapping.
Yeah.
And just out of curiosity, if this was, you did a very simplified protocol here for you know, practical reasons. Besides T1 mapping, is there anything else that you would have liked to have ideally that you think would have even enhanced these findings and our understanding of them?
Yeah, I think as Harish said, we didn't need to do LGE imaging. The likelihood, you know, that maybe a couple of patients would have had a little bit of RV insertion site LGE. I just wouldn't expect much LGE in this population. So, you know, I don't think there was a need to do that, but I think T1 mapping is the major thing we were missing. And then, you know, we would have liked to do an abdominal slice for abdominal visceral fat, but again, because of time and trying to keep the protocol simple, we didn't do that.
Great, awesome. So in summary, you know, Tirzepatide use in patients with HFpEF and obesity led to reduced LV mass and a newly coined term pericardiac adipose tissue compared to placebo. Interestingly, second summary point, no effect on what we traditionally would feel are functional assessments and strain and left atrial volume function and strain as well. And then the change in the LV mass within the intervention arm Tirzepatide group correlated with weight loss, which is self-explanatory, I think, given the nature of the primary study.
Apologies for the technical issues earlier. So now we're going to move on to sort of an open Q&A. So what I have just a couple of questions here to get our minds thinking. We don't have to talk about all of them. For all the participants, if you have questions you'd like to ask, please type them in the chat, and then we'll go through them from there. So just a couple things that were on our minds as we were putting this together. Does the reduction in LV mass contribute to the reduction in heart failure events seen in the main SUMMIT trial? And what about the pericardiac adipose tissue? What is the significance of the fact that the reduction was driven by a decrease in pericardial fat and not epicardial fat? And I would expand on that to say, do these two different types of tissues have different signaling properties? And then finally, since MRI assessment of fat mass and volume is not standard, is this something that cardiac imagers should apply, can apply? So just as a reminder, please type your questions into the chat and indicate if your question is addressed to a specific author. We'll go through them one by one, but maybe we could start off first with the questions on this slide as give people a few minutes to type in their own questions.
Yeah, so I think I would say the reduction in LV mass and volumes contribute to the reduction in heart failure events seen here. So I think if we studied 100 patients, the end diastolic volume would have been statistically significant, right? The p-value is 0.10. That was just a power. We were powered for mass, not for volumes. Volumes fell in the treated group. And I think the decline in mass and volume lead to, lower. So if you think about wall stress, right? Wall stress, it's a function of the diameter of the LV and the thickness of the heart muscle. Both fell. So wall stress falls. Blood pressure fell by 4 millimeters on average in the treated group. So pressure in the heart, in the left atrium, in the pulmonary capillary bed falls. So patients can exercise, they can do their activities of daily living, their KCCQ scores go up. All the parameters that Barry and Michael and Milton measured in the other papers improved, and it's all because of that reduction in hypertrophy and reduction in LV volumes, reduction in wall stress. So, again, we talk about restraint. I'm not a believer in restraint. I think we have an explanation here. If it was restraint, the volumes would increase, right? If you relieve the restraint, you would think volumes would increase. Here, the volumes are decreasing. So stress is reducing. The pressure in the heart is reducing. Back pressure in the lungs is falling. So that's where symptoms improved.
If I may, Dr. Packer, I couldn't help but notice you smiling with the discussion of restraint. Can you just fill us in on what you're thinking?
Oh, I'm only smiling actually from ear to ear because the steering committee, in addition to its devotion to making this trial in terms of design, execution, I mean, we really put our heart and soul into it. But the most fun we had was discussing mechanisms, because each of us came from a different perspective. Barry Borlaug, if he were here, would defend restraint. He would do it very vigorously. I, on the other hand, live in a neurohormonal world and would favor adipocytokines. And Chris says, gee, I only believe what I can see and measure. And
I guess where you stand depends on where you sit.
Exactly right.
If we can go to the second question on this slide, which actually was brought up in the chat as well. Is it the case that epicardial fat and pericardial fat have different signaling properties or different hormonal properties? And does it matter that the reductions that we're seeing are mostly in pericardial fat?
Yeah, I don't know. I don't know of measures of adipocytokine differences between epicardial and pericardial fat. I think it's an area of potential investigation. The group at UVA, the engineering physics group led by Fred Epstein, past chair of BME and MR physicist, is working on techniques to look at different components of epicardial and pericardial fat, namely, is it saturated or unsaturated or polyunsaturated, and does that play a role in HFpEF, obesity-related HFpEF? So I think there's a lot we need to learn in the coming years about the role of fat and the role of fat components, and is not just volume, and then ways of measuring adipocytokines, and then the whole concept of paracoronary fat that we can measure, the attenuation index by CT, and how that plays a role. So it's an exciting field that's just we're just scratching the surface on.
And if you could touch on the third question here too, is we sort of hinted at this a little bit. Is this something that in the future clinical MRI readers will be trying to assess fat volumes and using that to make or guide clinical decision making, or is this mainly relegated to research studies?
I think the adipose volume remains a research question. I think as imagers, we have to do a better job of explaining to clinicians the importance of LV mass. And we don't think about it. Echo, it's not that accurate, so we don't look at it in echo reports. We report it in MR, but I don't think anyone looks at it, because then people don't know what a normal value is, and or gender, age and gender based normal value, and what to do with it if it's elevated. So I think as a field, as cardiologists, we need to learn how to interpret LV mass values. Great.
Another question that's been on my mind, which also was brought up in the chat, and maybe this one is best for Dr. Packer. This trial is obviously looking at Tirzepatide. Other trials have looked at semaglutide. We know that there are other methods of weight loss that also have been shown to reduce inflammatory markers, bariatric surgery, for example. We know that exercise can reduce inflammatory markers. We know that healthy eating in certain ways and certain types of fatty acids can reduce inflammatory markers. All of these can promote weight loss. Do you think, all of these trials that have looked at GLP analogs versus placebo have obviously shown a significant impact in weight loss and inflammatory markers compared to placebo? Do you think this is just a universal effect of reducing inflammation and achieving weight loss by any mechanism? And I often joke with my fellows that the comparison for Tirzepatide should have been running and salad instead of placebo. I wonder, would that have achieved the same benefits?
Well, I don't know. Remember, these patients had a baseline body mass index of 38. I have a feeling that they were familiar with the healthcare system for a long time. But here I think is the most important question. What we're trying to do is change the biology of inflamed adipocytes, angry because they're expanded and their biology is changed, and that adverse biology affects cardiomyocytes. It affects how they work. It affects interstitial fibrosis. It affects the kidney, leading to sodium retention. We can't measure all of that by simply body weight. Remember, body mass index is substantially influenced by bone mass, skeletal muscle mass. These drugs can reduce skeletal muscle mass. So looking, and in heart failure, you can reduce weight by having a natriuretic effect, which these drugs do have. So I don't think that changes in weight are the right metric. We have biobank blood in Summit, And we hope to look at specific adipocytokines and maybe shed light, one, on mechanisms, and two, potentially identify some blood tests that perhaps people can measure in order to follow the effects of these drugs. But to get back to your original question, do I think that GLP-1 signaling and GIP signaling does things that other weight loss interventions do not do? I think the answer is yes. They act directly on adipocytes to change their biology independent of weight loss.
And with that, Dr. Packer, is there anything specific to the dual mechanism of tirzepatide with the GIP agonist that you think is particularly beneficial, or?
We don't know. The one thing that's really interesting is that if you take adipocytes and if you agonize, if you have an agonist effect on GIP, it has an additional anti-inflammatory effect. But it's, those are laboratory experiments. It's really hard to know how to translate them into the clinic. We're going to have data sometime next year that really addresses your question, and really I will pinpoint what GIP agonism really does.
And I guess one final question that I have, I'm a clinician, and so I'm sort of thinking a little more practically that unfortunately many of my patients will not be able to afford or receive tirzepatide for a variety of reasons. I'm curious, are there clinical insights that we can take from this trial that we can apply to patients even who may not be able to afford or receive tirzepatide? Are there certain things about inflammation or weight loss or LV mass that we may be able to extend to help people who can't get this drug?
Let me try to a sort of answer part of your question. And that is that when part of the access issues, and they're enormous with these drugs, is largely related to payers who say, we're not going to, we'll pay for the use of these drugs for diabetes, not for obesity. And the reason is we have half of the US population who is obese. We can't afford to cover these drugs. But if we can identify a high-risk population with obesity, and specifically obesity-related HFpEF, then I think access could be selectively channeled to these patients because their risk is so great and their benefit is so great. And so the risk to benefit relationship may not only just work out for patients, but it may work out for payers.
Great, thank you. And there was actually one more question that came up in the chat from one of our cardiology fellows, which, I think from a fellow's perspective is an interesting one to ask, which is, can you guys speak a little bit on the process of a study, conducting a study that is supported by industry? I think that's something that many fellows are curious to learn more about. How, to what extent is what driven by whom?
We really drove this trial. We designed it. We directed it. We played an extraordinarily activist role in discussions with FDA. I know that there's probably steering committees that play less of a role or may play a passive role. That was absolutely the opposite in this trial. We really had a very activist role, but we also had a very willing partner. Lilly was the sponsor of this trial. they partnered with us, and that's the ideal circumstance for an industry-sponsored trial. Remember, the NIH is no longer sponsoring traditional randomized trials of interventions. Industry is our only source of funding and novel drugs. We have to find a way to work with them that is very effective and rewarding. And this trial is a perfect example of the way that relationship should work.
Yeah, the same was true of the CMR sub-study. It was designed together. I mean, I developed the protocol, but in terms of choosing the endpoint, the primary endpoint, and additional endpoints, it was a discussion between the steering committee and Lilly, and it was the decisions were made together.
Great. Yeah, there was another comment in the chat about standardizing reporting of imaging measures like LV mass, which you mentioned, Dr. Kramer. And I think thank you everybody. We're coming to the end of our time, so we're going to go ahead and wrap up. This has really been a wonderful discussion for everyone. I apologize for the technical difficulties earlier, but hopefully it didn't interrupt our flow too much. Thank you very much to Natalie and Harish for putting together the slides and going through everything. And in particular, thank you very much to Dr. Kramer and Dr. Packer. This has really been a wonderful discussion. We really appreciate it.
Thank you.
Yeah, thank you for leading it. It was a really fun hour.
And this session is being recorded. The recording will be available on our Journal Club website. Please feel free to check it out. Tell your friends. And there will be more of these sessions to come. So stay tuned. Thank you, everybody.
Good night.